Ladies and gentlemen, I actually consider it a very proud privilege to be here amongst all of you today on this unique occasion actually, which Chaudhary has just highlighted. And I thank Dr. Yadav for giving me this opportunity to be here to introduce Dr. Anirudh Kohli today. Dr. Anirudh Kohli, as some of you may already know, especially the radiology fraternity, is a highly distinguished radiologist. He did his graduation from JJ Hospital, Mumbai, and right from his graduation and post-graduation days, he has been involved with all the latest technologies in radiology. He has been a great teacher. As far as the radiology is concerned, I think all the students will know him. He is seen at every teaching forum which is conducted in India, and not only that, he is a great teacher. So we are very fortunate to have amongst us a very unique teacher who conducts excellent courses, teaching courses, not only for undergraduates, postgraduates, for even the practicing radiologists. It's a treat to go and listen to him during his teaching programs, which he conducts regularly year after year. He has tremendous experience in various applications of CT scan as the CT has evolved over the years, and especially, when the technology is evolving, we always were concerned with the issue of coronary imaging. The issues were actually the motion, the spatial resolution, the temporal resolution, and always we wanted to get a little bit of information on the functional information as well as the myocardium is concerned. So many issues were actually in focus. We were trying to find solution, and towards this end, I think dual source has solved our problems to a great extent. So what has happened is, now we are in a position to image these coronary arteries irrespective of the heart rate very well. We are also in a position to get functional information about the myocardium, especially if the arteries are heavily calcified. There was a tremendous limitation earlier, and that limitation has been overcome now. More so in certain areas which are close to bone with calcification, like high carotid artery visualization, some structures very close to the base of skull. There were a lot of limitations which have been overcome, and I'm sure Dr. Anirudh Kohli is going to enlighten us with various applications how this technology has made a tremendous difference. And I request Dr. Kohli now to kindly give his overview on various applications about 128 and dual side CT. Thank you.
Okay, can we have the lights down? Thank you, Dr. Chandramohan. He's a friend, so discount 90% of what he said. Okay, he's very kind to me. But anyway, let's get on with the evening. And what I'm going to be speaking about is something which is extremely important to every individual in this room, because it's about coronary artery disease. And everybody knows that everybody is a possible candidate for coronary artery disease. And the key to coronary artery disease is detecting it early and managing it as well as possible without really having to go and have myocardial infarction, reduced cardiac function, and even possibly going on to bypass surgery. So if we can detect it early, manage it early, it's very, very important. Can we get the lights a little more down? So what I'm going to launch into this directly is very simply because we have something known as dual source CT. The dual source CT, what I'm showing you here, is just a pictorial diagram to show you. It's actually two CT scanners in one. That is what has made a huge difference and huge change. It's been a difficult change to accept, because as soon as you have two CT scanners in one, you can understand the price is double. Okay, so that's a major limitation, but the major advantage is what it gives us. One of the main things that a lot of people ask us is that over the years we've done cardiac CT, and in fact I've done 4 slides, 8 slides, 16 slides, 64 slides, and now we're working with a dual source CT. What is it, and why is it that you need to go for this technological advancement and go for this machine which has 2 CT scanners in it? For a fundamental reason. What we've been using, and which is still also being used, is what we call a single source CT, which has only 1 CT scanner inside. What were the issues with that? Heart rate. If you had a heart rate which went above 65, the scans would come poor. Not only poor, high incidence of false positive, very poor correlation with cath angio. If the heart rate changed more than 15 beats during the scan, again, the images are marred and you don't have a confidence level to be sure what you're seeing. If the ectopics, arrhythmias, those scans are not possible. High calcium scores, in fact, recommendation is any calcium score above 400, don't scan. Total blocks and collaterals, whether there's a total occlusion of the vessel and the vessel is actually filling up distally by collaterals. And it's essentially the problem with single source CT scanners was a lower temporal resolution. So when you looked at that and you looked at the cath angio, they didn't correlate well. And if we have to do anything today non-invasive, it has to correlate very, very well with the invasive test. And that's when only it's of utility. And especially talking about something so important like the coronary arteries. Today people do talk about radiation, not that I feel radiation is such an important issue, because after all we're talking about somebody's life. And myocardial infarction, coronary artery disease, but dual source CT also gives much lower radiation than single source CT. So let's look at all these points. And in fact, in case I go on too long, just stop me, Dr. Yadav, and say, enough, and we can move on. So I'll just run through examples with you. High heart rate. If we look at high heart rate, this is a patient with a heart rate of 88 to 95. And you can see absolutely beautiful coronary artery pictures of the RCA, the LAD, and here's the ECG. And I'm going to show you ECGs as we go along. And these ECGs that you will see are taken during the scan. Where you see these vertical boxes out there, those are actually the scan is on. So I'm just proving to you that we're not faking it, that this is actually the heart rate when we scan the patient. Here's another one where you can see the coronary arteries beautifully. You see the circumflex, you see the RCA, you see the LAD, absolutely beautiful normal vessels with a heart rate of 96 to 107. And again the ECG to prove what I'm saying. Here you can see that there is a focal lesion in the LAD which is causing stenosis, and we see it so well with a heart rate of 96 to 100. These do not cause any problem to us. Here you can see an absolutely beautiful image of the LAD in its full course. You see that in what we call the curved NPRs also, very nicely seen in all views. Even you see the OM so well. And what is the heart rate? 107 to 117. And that's the ECG to prove what I'm saying. Again, here you can see very, very nice coronary pictures, 100 to 109 heart rate. Again, the ECG to prove that point. Here's one where you can see the heart rate is 109 to 115. And again, beautiful pictures of the coronary arteries. You see the VRTs, they're lovely pictures, showing that vessels so beautifully well. Here, again, you can see very, very nice pictures of the coronary arteries, VRTs in all perspective, with a heart rate which is 115 to 120. So I'm going higher and higher, and still you're seeing excellent coronary arteries. Here you see one with a small plaque here in the mid-LAD. Good views of the RCA, the circumflex, the OMs, and the heart rate 125 to 136. And here's one where you can see very nice VRT pictures, very nice pictures of the LAD, very nice pictures of the RCA, and the heart rate 133 to 136. So heart rate is not a limitation. We don't beta block these patients. It's not a limitation, and we see pristine image quality. I've shown you normals, and I'll show you abnormals also with heart rate, high heart rates later. The other issue was heart rate variation, as I said, an issue which was with the single source CTs. 57 to 72, something which would just not be acceptable on a single source CT. And here you can see absolutely beautiful, perfect image quality. You rotate the image around, you can see the PDA well, you can see the RCA well, and you see the coronary arteries on the curved MPRs. We need both these type of images, and you can see them beautifully pristine quality of the coronary arteries, 46 to 98. Again, the ECG to prove what I'm saying. And you can see the coronaries, there's no interference with such a high heart rate variation. You see excellent, excellent pictures. 61 to 90, again, a high heart rate variation, and again, very, very nice pictures. 47 to 96, again, ECG, and you see these vessels. 50 to 117, again, and perfect image quality. Doesn't interfere with the image quality, and I can go on and on showing you pictures, and in fact, we have hundreds of cases up on our website, and you can go and see them. 78 to 136, huge variation, and you can see that the coronary arteries are beautifully visualized very nicely. The third point I said was about ectopics and arrhythmias. Well, let's look at this ECG out here. What do you see? One ectopic there. What do you see? Another ectopic out there. And then when you look at the coronary arteries, you can see very nice image quality, not interfering with the image quality of the coronary arteries. Let's look at this one, ECG. There's one ectopic there, there's another ectopic out there, and we can see that the coronary arteries are beautifully imaged again. Here with multiple ectopics, and again, not interfering with the coronary arteries. I must say that there are occasional times when we need to do a little bit of editing, a little bit of moving our cursors around to get good quality images, and occasional, very, very occasional, it may be difficult to do that. Here's one where you can just see the number of ectopics. There are 5 ectopics during this thing, and the image quality is good. Atrial fibrillation is something which is absolute no-no with single source CT. Here's the ECG, no P waves at all. And look at the CT angio images, absolutely beautiful. So now let's look at clinical issues. I've proven to you that this is a great technology to look at normal coronary arteries. Well, let's look at pathologies now. Bypass grafts. This is something which really brought us in to looking at cardiac and really to see the patency of bypass grafts, which is very important. Here you can see very nicely out here, you see the Lima graft coming down, anastomosing with the LAD, and what's very, very important to show is actually the anastomosis, and that's quite nicely seen out here. You see the anastomosis well, you see the native vessel well, and you also see the competitive flow. Here again, you see an SVG graft out here, and that's the SVG graft on the VRTs, and the clinician wasn't too sure. This is a new technology. I'm not sure whether the grafts are patent. He went ahead and did the cath angio, and that's the cath angio showing you the graft exactly like what you saw. Here's an example of an SVG graft with a plaque in the mid-segment, very nicely seen on the curved MPRs and beautifully seen on the VRT images. Here again, you can see focal stenosis out here in an SVG graft. In fact, you can see that quite nicely on the VRT images also, and then up, because it's a rotated VRT image, and that's why you're seeing it up out there. And here, for example, you can see that there's total occlusion of the SVG to the LAD graft, seen quite nicely on the curved MPRs, as well as on the VRT sections. You see it, and then you get a cath angio done to confirm it. And what is, look at the images. They absolutely look exactly the same. Well, congenital anomalies is an important thing, because when we scan, we do see anomalies with the origins of coronary artery. In fact, that's very important sometimes for the cardiologist, interventional cardiology, when he's going to do a cath angio. This, of course, is just a myocardial bridging, which is a focal narrowing during systole. You can see it quite nicely on the VRT images also, and it opens up. But here you can see very nicely that there is a circumflex, which is originating from the RCA, from the right coronary cusp, and it's traversing around. And these are different VRT images showing you the course of the circumflex, which is originated from the RCA, and as it comes behind the aorta and goes into its normal position. Here's an example of a RCA arising from the left coronary cusp. So it's like a single coronary artery with, the left main out here, and the RCA